Now let's talk about the autonomic nervous system, and we'll be talking about the sympatho-mimetic agents first. Sympatho-mimetic agents means those which mimic sympathetic nervous system, and this nervous system activates when you are ready to fight or flight, right? So alpha 1 receptors, these are the adrenergic receptors. We'll be looking at action of different adrenergic receptors. Alpha 1 receptors are located on the blood vessels. When they're stimulated, they do vasoconstriction. So phenylephrine is one of the alpha 1 agonists, and during erection of penis is the vasodilatation which makes the penis erect. So alpha 1 receptor agonists like phenylephrine are contraindicated in erectile dysfunction, right? Alpha 2 agonist, as central alpha 2 agonists like dexmedetomidine acts on central alpha 2 receptor that's present in the midbrain, which decreases the blood pressure, has sedating, analgesic and anxiolytic effect. That's why it is also used as an anesthetic agent. Some of the alpha 2 agonists also decrease the aqueous humor production like brimonidine, which is used as anti-glaucomic drug. Beta 1 receptors increase the heart rate, and pure beta 1 agonist is dobutamine, which is used as positive inotropic agent in heart failure. Beta 2 agonists like salbutamol, salmeterol and terbutaline does bronchodilation and vasodilatation. Salmeterol is longest acting beta 2 agonist, and terbutaline is also available in subcutaneous injections, right? Alpha 2 agonists cause all of the following, except it does not cause hyperalgesia, right? Rest 3 are its action. Hyperalgesia means more pain. It prevents pain. Dexmedetomidine is central alpha 2 receptor. Longest acting is salmeterol. सालों तक चलता है. So the following injection is available in subcutaneous, that's terbutaline. Sympatho-mimetic drugs are useful in all of the therapy except, look, I said sympatho-mimetic drugs does vasoconstriction with the help of alpha 1 receptors. This shouldn't be given in erectile dysfunction. Which one of the following agent is not used in treatment of erectile dysfunction? Prostaglandin E is helping in vasodilatation, and prostaglandin E analog is alprostadil. So these both are same thing. Vardenafil or sildenafil, these are phosphodiesterase 5 inhibitor, PD5 inhibitors. Sildenafil and vardenafil, also sold as a brand name Viagra, right? These causes vasodilatation and help in penis erection. But beware boys, this also causes color blindness, right? Color blindness. Don't take Viagra, right? Now let's compare norepinephrine, epinephrine and dopamine, right? Norepinephrine mainly acts on alpha 1 and beta 1 receptor and has little bit action on beta 2 receptor. With the help of alpha 1 receptor, it does vasoconstriction, and with the help of beta 1 receptor, it increases heart rate. So it net effect of its action is increase in blood pressure, right? Epinephrine equally acts on alpha 1, beta 1 and beta 2 receptor, and this increases blood pressure, and with the help of beta 2 receptor, it can also do bronchodilation. And dopamine action is dependent upon dose, right? On low dose of dopamine receptor in the kidney are stimulated, and it does vasodilatation in kidney, and hence increasing the GFR in the low dose. If you increase the dose of dopamine little bit, it will also act on beta 1 receptor, which increases the heart rate. And if you still increase the dose of dopamine, alpha 1 receptor will do vasoconstriction, right? So the action of dopamine is dose dependent. So which of the following is true? Dopamine increases the hepatic and mesenteric blood flow at high dose. No, high dose activates alpha 1 receptor and it does vasoconstriction, so blood flow will be decreased. Dobutamine decreases peripheral vascular resistance. Dobutamine mainly acts on beta 1 receptor, but sometimes it also acts on beta 2 receptor and causes vasodilatation and hence decreasing peripheral vascular resistance. Right? Noradrenaline increases the renal blood flow. Adrenaline causes selective renal vasodilation. Nope. Both of these act on alpha 1 receptor and causes vasoconstriction, so decreasing the renal blood flow. Let's talk about the cholinergic system. right? Here are the muscarinic receptors. We have two sort of receptor in cholinergic system, the muscarinic receptors and nicotinic receptors. So M2 type of muscarinic receptor on stimulation decreases the heart rate. They are present in the SO node and AV node. So drug like pilocarpine, which is a cholinergic drug, decreases the heart rate, right? M3 receptors, almost all of the structure in the body are innervated by M3 receptor, be it glands, and on stimulation glands increases their secretion, right? Be it parotid or submandibular gland, there will be more salivation, more GIT secretion. It also does bronchoconstriction. Therefore cholinergic drugs are not to be given in asthma, and anticholinergic drugs like ipratropium and tiotropium are helpful in asthma because it prevents bronchoconstriction. It also increases spasm of intestine. Therefore anticholinergic drugs like glycopyrrolate are helpful in abdominal spasm. It increases urination. Its clinical importance lies when you give anticholinergic drugs, this urination would be decreased, and please don't give this anticholinergic drugs where there is urinary retention. So all of the following are therapeutic indication of Cholino-mimetics, except we said that with the help of M2 receptor it decreases heart rate, so they are contraindicated in bradycardia and heart blocks, right? So bradycardia and heart blocks are absolute contraindication of Cholino-mimetic drugs. Ipratropium is contraindicated in urinary retention. Ipratropium blocks the M3 receptor. So M3 receptor, when they are stimulated, they contract the urinary bladder and you urinate. Now if M3 receptors are blocked, you cannot contract your urinary bladder, so urine will be retained, and at the top that patient has urinary retention problem. So this is a whole lot of a big problem. Tiotropium is used in treating asthma because it blocks M3 receptor and prevents bronchoconstriction. Which of the following is not a tertiary amine derivative? All of these are anticholinergic drug, and tertiary amine means those which are derivative of tertiary amine can cross the blood-brain barrier. That means it can act on brain. So scopolamine and hyoscine, which are also used for motion sickness, definitely has to go to brain. So these are definitely derivative of tertiary amine. Atropine has also some effect on brain, so it is also a tertiary amine. So the only drug which is not tertiary amine is glycopyrrolate, and that's why it is only restricted to GIT action, the M3 receptor. Let's talk about the anti-glaucomic drugs. There are two modalities of treatment when the patient is suffering from glaucoma, that is raised intraocular pressure. Either you decrease the secretion of aqueous humor or you increase the outflow of the aqueous humor. And the way by which you decrease the secretion of aqueous humor is by beta blockers, alpha 2 agonist, or carbonic anhydrase inhibitors, right? Beta blockers can be selective or non-selective like bitoxolol and timolol, alpha 2 agonists like brimonidine, and carbonic anhydrase like acetazolamide. You can increase the outflow of aqueous humor, be it trabecular outflow or uveoscleral outflow. Trabecular outflow can be increased by pilocarpine, and uveoscleral outflow can be increased by prostaglandin analogs like latanoprost and travoprost. A patient with glaucoma is being treated with systemic beta blockers. You cannot give him levobutanol because levobutanol is topical beta blocker, non-selective topical beta blockers, and when two beta blockers combine, it inhibits heart more, so that's more sort of dangerous thing. Correct match in anti-glaucoma is brimonidine, which is alpha 2 agonist, decreases the aqueous humor production. Latanoprost increases the uveoscleral way. Pilocarpine increases the trabecular outflow. Bitoxolol decreases the aqueous production. Mechanism of action of pralidoxim is, this drug is used in organophosphate poisoning. What happens in organophosphate poisoning? Suppose here is your nerve ending and here is your, say, neuromuscular junction. When acetylcholine is released, it is normally degraded by acetylcholine esterase, right? So acetylcholine esterase is normally degrading the acetylcholine. What happens when organophosphate poisoning is there? Organophosphate poisoning blocks this acetylcholine esterase, so there will be no more degradation of acetylcholine. So acetylcholine will be increased in the synaptic cleft. right? So what's the action of pralidoxim is it reactivates the cholinesterase by removing this block, right? So pralidoxim. Methacholine on heart acts primarily on, you remember we talked about two type of muscarinic receptor, the M2 and the M3, and I said M3 receptor are present at almost all places and M2 receptor are present mainly on heart, right? And on stimulation of M2 receptor they produce bradycardia, right? And that's why they were contraindicated in partial heart blocks. So methacholine is one of the cholinergic drug like acetylcholine. So you have three cholinergic drugs to remember: methacholine, acetylcholine, and the pilocarpine, which I gave you the example in the previous slides. So the answer is M2 receptor. Drugs having both alpha and beta agonistic activity. Let's derive the answer. What about dopamine? Dopamine acts on dopamine receptor in the kidney, acts on beta 1 receptor, and little bit action on alpha 1 receptor, right? We talked about this one. Phenolidopam is purely dopamine agonist, right? Only acts on dopamine receptor. Phenylephrine is alpha 1 agonist. Epinephrine acts on all the receptor, alpha 1 receptor, beta 1 receptor, and beta 2 receptor. So having both alpha and beta agonistic property, epinephrine.